There are some questions from the participant in the chat, and one of the first of all, I want to acknowledge your brilliant talk. Really, you have contributed very much to the advance of how can be modulated the myeloid-derived suppressor cells in this types of cancer, and the proof is that there are several clinical trials on the use trying to modulate this immunosuppressive activity of myeloid-derived suppressor cells. There are, as I say, several questions. One of the questions is related to how aging affect myeloid-derived suppressor cells. Do you have any experience on how these cells are affected by senescence, by aging?
Yeah, so thank you for this question. So we did not study this particularly, but on the other side, you know that the generation of MDC so happened in principle not in the normal conditions where steady state condition where T cells are not activated. And since chronic inflammation, so which leads to the constant activation of T cells, actually also happened more, let's say, often in the aged persons. So in general, one could say that the activity of MDC so could be higher. But I think it's a very important point which should be studied, and especially in the clinical setting. So just comparing the different groups of patients. But for this, one should use, of course, I think the cohort of people just having like really strong difference in the age.
Okay, thank you. There is another question about the TL4 polymorphins, how these polymorphins can affect the induction of myeloid-derived suppressor cells from monocytes. Is there any study of this on this subject?
Yeah, so this is also a very important point. So indeed, polymorphism can affect the induction. So we don't have the clinical data so far, but it's known because there is also different pattern of toll-like receptor 4 expression. So in different patients, so which can also be correlated with the possibility for monocytes to be converted into the immunosuppressive cells. Yeah, this is true. It can be really a factor. But again, we don't have at the moment still the conclusive data on this point. It's only at the moment like more or less hypothesis.
Which do you think is the best experimental approach or clinical trial approach to modulate the immunosuppressive activity of these cells? Do you think it's more easier to use some drugs as maraviroc that blocks the chemostasis, or other, or for instance the other one, the tadalafil, or combination of both?
Yeah, I think it's also a very good point, very good question. So I think that the strategy would be probably like this. So it's not only dealing with the static of particular MDC, but also in general immune system. So that immunologists should really take part in the decision of the treatment of patients. So not only surgeons or therapeutics or radiologists. And what will be important is to have like immunomonitoring, not only during the treatment, or after the start of the treatment, but also before, and on the basis of this, just to decide what we can use. Unfortunately, at the moment, we don't have the privilege, just to have many factors targeting MDC already approved for the treatment. Therefore, I think that the most realistic and feasible approach would be just to use different targeting factors, like, for example, Maraviroc. I think it's a very good one, just in the combination with immune checkpoint inhibitors. So our colleague from the KFZ and working also in Mainz, in Tron, Niels Hallemann was made already, or now it's in the process, of clinical trials in colon cancer patient, but he tried also to combine Maraviroc with immune checkpoint inhibitors, and the trial is still in process. So he presented only some preliminary data, but they are promising in any case. I would say that the blocking of migration, so you can use in any case, of course, would be important to know what is the frequency, the percentage of this CCR5 positive MDC among the whole population in this or other patients. So this will be the important factor to decide if to use Maraviroc or not. Because if you have, like, as we had, for example, in human settings, that some patients, so they have like 70-80% in circulation among all MDCs, so they were 70-80% CCR5 positive, then of course for this patient it will be really, really very, very important and very powerful tool. For others, if they have less, because there is a heterogeneity anyway. Why it happens, it's also really very important, very important questions which can discuss if you like, because we found why CCR5 is upregulated, and that if CCR5 is really involved in immunosuppressive function. But shortly telling, the level or the frequency of CCR5 expression could be a very good tool to decide for this. If, for example, you have again the expression of Toll-like receptor 4 and studying the polymorphism of this expression in the monocytes. So this will be the point to use, for example, Rezatorvit. Rezatorvit was used already in some clinical trials, but with completely different aim, not thinking about MDC, so without good effect. And so people somehow forgot about this. But if we will find a cohort of patients having a strong expression of Toll-like receptor 4 on monocytes, right? So this could be, of course, additional mechanism. What I'm, for example, using tadalafil for sure, it could be a good factor. The only thing, it's necessary to start earlier. I mean, not already when the patient is completely resistant to any type of therapies. I would propose this to start even without any important significant side effect, to start really just together with treatment with immune checkpoint inhibitors. In melanoma, unfortunately, again, we have really the domination of this treatment with immune checkpoint inhibitors. So the doctors are obliged to use these antibodies. So therefore, we don't have other way as to use the combination.
I think it's very, very interesting. It's a broad range of new possibilities using the modulation of, or the combination of checkpoint inhibitors with these new possibilities to block or to inhibit the function of these myeloid-derived suppressor cells. And also, is there any consideration of inhibiting mediators of TGF beta or IL-10 that are also involved in this immunosuppression? Or do you have there is any evidence on that? Or
Yes. It's also another factor. So, well, TGF beta is so to say pluripotent factor, so involved in the immunosuppression, not only involved in the not only dealing with the production of TGF beta, for example, by MDCs. Yes, it can be also done. Absolutely. So there are there is, of course, and there are antibodies against TGF beta, but since it's a pluripotent also factor, so, and could be like the different effects, one should look also on the possible side effects. There are some also studies, and I think also made in Spain, I think, using the small molecules, so inhibitor of the TGF beta, so which blocking the interaction between TGF beta and TGF beta receptor. So this could be probably much cheaper, of course, than antibodies, and probably even more effective in the blocking of TGF beta. Yes, of course, it's important. With IL-10, there is it's a good point. So people are also trying to draw, by the way, also small molecules just blocking the interaction of IL-10 with IL-10 receptors. Although there are some data showing that IL-10 could be important also for some T cells or generation. So therefore, well, the study should be continuing. So we made a lot of also study with IL-6, because IL-6 was clearly shown to be involved in generation of MDCs, and then in vitro it works absolutely perfect. So you can block the generation. So and IL-6 is needed not only for proliferation of myeloid cells, but also for acquisition of immunosuppressive activity of the precursors. However, when you use, for example, the antibodies against IL-6 in mouse model, so we did not see any effect at all on the tumor growth. So tumor growth perfectly and without any difference. So the point is that probably IL-6 in the body is needed also especially for activation of T cells. And therefore, when we use antibodies, so if it has like double effect, positive and negative, and at the end you have zero result. Yeah, so this would be important also to take into account how in vivo, in the full immunocompetent organism, well, in mice, for example, or then in human. So your treatment can work also on the other cells. Yeah. Therefore, it's not, well, really not so easy. I would probably concentrate on the factors which are particularly important for immunosuppressive activity, particularly myeloid cells. And in this case, well, we have very good story with PD-L1. Of course, one can tell, okay, we have perfect antibodies. However, there is still a resistance to some patients. So in melanoma, we have like only 40% maximum of patients who responded, which is a lot, but we want more. So therefore, one should study really what happened exactly in this particular patient resistant with PD-L1 expression. So probably some other factors produced by MDC can be involved in the immunosuppressive property of MDCs, right? And then another possibility is again to use probably some small molecules not so expensive as antibodies and not probably bringing such a high side effects. There are some work on this, for example, using so-called I-bodies, so chemically engineered small molecules just binding to PD-L1 cells, so and which can do the same effect.
Okay, thank you very much, Victor. I fully agree with you in that the immunology should be contacted by the clinical before they introduce new therapies. So for each particular patient, the response to the different patient is very different. How each different cancer has evaded the immune system in each patient is different, and we really can contribute very much by analyzing how the immune system, the cancer cells, and contribute to providing information that can help very much to a better diagnostic and treatment of this patient. I really, and your discussion, your talk has been very informative on that. If there is no any more question, does Graham, do you want to say anything on that, or?
I would like to say that thank you very much for your participation as host and speaker. That was very informative and very interestingly described how the vast amount of data on MDSCs is so critical for both mouse and human outcomes, and particularly in melanoma, but we know that's also the case with other tumors as well. So I think this is an indication of how important it is, since we have all this information, but we don't know what happens in older individuals, neither mouse nor humans exactly. There are still no trials, no clinical trials specifically in older humans, as far as I'm aware. That might not be the case currently, but this is not certainly not any published ones. There are anecdotal data, of course, because older people are included in many of the clinical trials, and one can dissect out sometimes which responses and which functionalities are belonging to the older cohorts. We know, of course, that the skewing of the hematopoietic system in old individuals, both mice and humans, means that a larger number of myeloid cells are produced at the cost of fewer T cell progenitors and B cells. So you would expect that there might be some age-associated effects, plus the fact that this well-known phenomenon of inflammaging is present in most older people. That is to say, higher background levels, not those seen in acute infection, but chronically raised levels of inflammatory mediators in older people would suggest that with the increased number of myeloid cells being produced plus inflammation, you should be getting a much stronger effect on myeloid cells, or of MDSCs indeed, in older individuals. And this might be expected to impact their treatment of any kind, but particularly those relying on immunological means such as ICD. However, as far as one can see from looking at the anecdotal data, and our own experience as well, older individuals, older melanoma patients, do not seem to have a deficit in their response to checkpoint blockade, in that they do just as well. Some other data suggests that people over 70 might even do a bit better than younger individuals under PD-1 treatment. So I think that given all the information, the fantastic overview that we just heard from Victor on all the details of MDSC production and function, it's crucial to know which aspects, if any, are really affected by aging. And that's why it's so important to have a journal like the ACRT, where we can try to assemble groups of individuals who may not have known that they're interested in aging particularly, but where one can point out the fact that aging of the immune system and other physiological systems in humans and animals do contribute in ways that are not yet determined, but could be showing a hidden background that's extremely important to dissect out. So that's why I would encourage everybody to try to think about what they can contribute to the journal, as well as speaking at these webinars, which was a fantastic beginning. I hope that we can continue and that we will have more enthusiastic participation from the outside world, particularly the editorial board members of the journal. I didn't see that there were too many of them actually participating in this webinar. So thanks again to Rachel for organizing the webinar, to Raphael for hosting the webinar, and to Victor for the fantastic talk. Thanks very much again. Bye.